Complex surgical techniques to overcome pancreatic cancer involving major blood vessels. Hello, this evidence-based content is prepared by Saboor fellowship-trained consultant surgeon, and if you or someone you care about has been told a pancreatic tumor is borderline resectable, you're in the right place. I know these words can feel overwhelming. Maybe you're wondering what borderline even means, or whether surgery is still an option. Today we're going to understand exactly what borderline resectable pancreatic cancer is, denoting whether or not it can be removed. This is due to proximity to major blood vessels, and how modern vascular reconstruction techniques are giving patients surgical options that didn't exist a decade ago, and what this means for you or your loved one. By the end, you'll understand why the definition of resectable keeps evolving, what specialized surgery can accomplish, and the specific questions you should be asking your medical team. Borderline resectable pancreatic cancer sits on a continuum between clearly resectable, which means removable with surgery, and unresectable, which denotes disease that cannot be removed with surgery. The key difference isn't just about tumor size. It's about the tumor's relationship with critical blood vessels near your pancreas. These include the superior mesenteric vein, portal vein, and superior mesenteric artery. The term borderline resectable was proposed to identify patients whose tumors have limited vascular involvement that's potentially amenable to resection and reconstruction, though with a higher risk of incomplete tumor removal. This matters enormously because surgical resection offers the only chance of cure for pancreatic cancer. According to the National Comprehensive Cancer Network guidelines, which are based on consensus from leading pancreatic surgeons, specific criteria define this category. For tumors in the pancreatic head, borderline resectable means solid tumor contact with the main veins that drain blood to the liver, which are superior mesenteric vein or portal vein greater than 180 degrees. That's more than half the vessel's circumference, with contour irregularity or thrombosis, but critically with suitable vessel above and below the tumor, allowing safe resection and reconstruction. Encasement or occlusion of the superior mesenteric vein or portal vein was previously considered unresectable. However, with increasing experience in vascular reconstruction, many centers have demonstrated the feasibility of reconstruction, and this is now considered borderline resectable disease by many surgeons provided suitable vessels exist for reconstruction. Think about what this means. Tumors that would have been deemed inoperable 10 to 15 years ago can now potentially be removed at specialized centers. The NCCN definition is difficult to reconcile with standard cancer staging systems. One study found that 30% of patients with stage 3 disease, previously categorized as unresectable based on arterial involvement, could undergo successful complete tumor removal after chemotherapy or combined chemotherapy and radiation. About 30 to 40% of pancreatic cancers involve major blood vessels at diagnosis. Tumors with limited involvement of major vessels like the superior mesenteric vein, portal vein, or superior mesenteric artery may be technically resectable, though this requires specialized surgical expertise. An R0 resection means no tumor present at the margin, as shown in this diagram. Venous resection and reconstruction has now become a standard approach at experienced centers. We're talking about pancreaticoduodenectomy, often called the Whipple procedure, combined with portal vein or superior mesenteric vein resection and reconstruction. This is performed when adequate inflow and outflow veins are present, and an R0 resection, meaning clear margins with no cancer at the edges, can be accomplished. The depth of invasion matters significantly. Deeper invasion to the vessel's inner layer carries poorer outcomes compared to superficial involvement of just the outer wall. Adding vein resection to pancreatic surgery increases complexity and risk. When compared with standard pancreaticoduodenectomy, adding superior mesenteric vein portal vein resection increases complication rates and may increase mortality even at very high-volume centers. Portal vein thrombosis, blood clots in the reconstructed vein, develops in about 16% of patients at a median of 15 days after surgery. Portal vein thrombosis, when a clot forms inside the vein following surgery, carries increased 90-day mortality of 16.7% versus 4.9% without thrombosis. This is why careful patient selection is mandatory, and why these procedures should only be performed at high-volume centers generally after neoadjuvant treatment, chemotherapy given before surgery to shrink the tumor. By contrast to venous resection, most experts do not advocate arterial resection and reconstruction for the superior mesenteric artery, which is one of the two major blood supply routes to the gut, as shown in this diagram. The superior mesenteric artery courses behind the pancreas and is located behind the superior mesenteric vein, which makes arterial involvement unlikely without simultaneous vein involvement. Multiple systematic reviews associated arterial resection with higher risk and potentially poor short and long-term outcomes, so there's limited evidence to support arterial resection outside clinical trial settings. One exception exists: tumors of the pancreatic body involving the celiac axis or common hepatic artery. Both can be resected without reconstruction as long as adequate retrograde blood flow exists through the gastroduodenal artery, a procedure known as the modified Appleby procedure. However, this remains a specialized technique not widely performed. In addition, there are reconstruction options in specialist centers. Patients with borderline resectable disease differ from those with clearly resectable disease in crucial ways. They're at high risk for positive resection margins due to tumor abutment on arteries. They require more complex operations usually involving vascular resection, and they may be at higher risk of harboring undetected metastatic disease. That's why at many centers, all patients meeting criteria for borderline resectable disease because of vascular involvement are referred for neoadjuvant treatment, chemotherapy, given before surgery to increase the likelihood of margin-negative resection. The major goal is an R0 resection. Margin-positive resection strongly predicts early recurrence and short survival. The term borderline resectable was specifically proposed to identify patients who would benefit from neoadjuvant therapy with the expectation that downstaging would provide enhanced opportunity for complete resection and long-term survival. As the name suggests, the surgery is not assured to remove the tumor, hence borderline. A meta-analysis of 38 studies in patients with potentially or borderline resectable pancreatic cancer found that neoadjuvant treatment, which means providing chemotherapy before surgery, provided similar overall survival compared with upfront surgery, with weighted mean overall survival of 18.8 versus 14.8 months. However, the difference was larger among patients whose tumors were actually resected, showing benefit for chemotherapy before surgery. Here's the rationale. It improves patient selection for surgery by identifying those who rapidly progress during therapy and likely wouldn't benefit from resection, increases rates of margin-negative resection, and provides early treatment of micrometastatic disease that might already exist but isn't visible on scans. Of the 7 margins examined during pancreatic surgery, the superior mesenteric artery margin is the most important driver of tumor recurrence because it's the most frequently involved positive margin in up to 85% of cases, and there's no protective fat tissue between the adjacent part of pancreas called uncinate process of the pancreas and this artery. You can see this in the cartoon. The SMA in red denotes the artery. For venous resections, accurate assessment of vessel invasion is mandatory. The depth is categorized as superficial deep or true tumor at the inner vessel lining or in contact with the vessel lumen. Deeper invasion was found to be an independent predictor of poorer survival in multiple studies. In contemporary series from high-volume centers, median survival for resected pancreatic cancer ranges from 16 to 27 months, with newer multi-agent adjuvant chemotherapy regimens significantly increasing both median and 5-year survival. When vascular resection is added, the survival benefit is variably reported, most likely due to differences in the completeness of resection achieved. Recovery from pancreatic duodenectomy with vascular reconstruction typically requires hospital stays of 1 to 2 weeks, with full recovery taking 2 to 3 months before adjuvant chemotherapy can begin. Borderline resectable does not mean inoperable. It means complex surgery requiring specialized expertise. If you've received this diagnosis, the tumor has specific vascular involvement that experienced surgeons can address with vascular reconstruction techniques. Not all centers have equal expertise. The feasibility of vascular reconstruction varies significantly by institutional experience. These procedures should only be performed at high-volume centers with specialized pancreatic surgeons experienced in vascular reconstruction. Most patients with borderline resectable disease will receive 4 to 6 months of neoadjuvant chemotherapy before surgical exploration. This isn't delaying treatment. It's optimizing your chance of successful complete resection. CT scans assess disease extent. Multiphasic computed tomography of the chest, abdomen, and pelvis will determine the degree of vascular involvement and help determine if you meet criteria for borderline resectable disease versus truly unresectable. Your first question should be, based on my imaging, what specific vessels are involved and to what degree? Get precise answers about whether it's the superior mesenteric vein, portal vein, or superior mesenteric artery, and whether involvement is less than or greater than 180 degrees of the vessel circumference. In this cartoon, the main arteries are in red and the main veins in blue. By contrast to venous resection, most experts do not advocate arterial resection and reconstruction for the superior mesenteric artery, which is one of the 2 major blood supply routes to the gut, as shown in this diagram. The superior mesenteric artery courses behind the pancreas and is located behind the superior mesenteric vein, which makes arterial involvement unlikely without simultaneous vein involvement. Multiple systematic reviews associated arterial resection with higher risk and potentially poor short and long-term outcomes, so there's limited evidence to support arterial resection outside clinical trial settings. What is your center's experience with vascular reconstruction for pancreatic cancer? You want specific numbers. How many of these procedures they perform annually, their R0 resection rates, and their complication rates? What neoadjuvant treatment regimen do you recommend and why? Options include FOLFIRINOX, a combination of 4 chemotherapy drugs, or gemcitabine-based regimens. The choice depends on your performance status, age, and overall fitness. After neoadjuvant therapy, how will you reassess resectability? Imaging after chemotherapy can be challenging to interpret, particularly after FOLFIRINOX. Many centers offer surgical exploration to all patients without documented metastatic disease. If surgery is successful, what adjuvant therapy, that is, chemotherapy after surgery, would you recommend? Even after neoadjuvant therapy and complete resection, additional chemotherapy is often recommended, though the optimal duration remains under study. Immediately upon diagnosis of borderline resectable disease, given the complexity of these cases, evaluation at a high-volume pancreatic surgery center should happen before treatment decisions are made. If your local oncologist recommends chemotherapy alone without discussing potential surgery, while some cases truly aren't resectable, borderline resectable disease specifically exists in the category where specialized surgery after neoadjuvant therapy can be curative. If you're told the tumor is unresectable based solely on vascular involvement, definitions have evolved significantly, and what was considered unresectable a decade ago may now be approachable at experienced centers. Before starting any chemotherapy regimen, ensure you've had evaluation by a multidisciplinary team, including a pancreatic surgeon experienced in vascular reconstruction. This doesn't delay treatment. It ensures you're on the optimal treatment pathway from the start. Borderline resectable pancreatic cancer involves specific vascular relationships that specialized surgical techniques can now address through vein resection and reconstruction. Your next step: seek evaluation at a high-volume pancreatic surgery center with vascular reconstruction expertise before finalizing your treatment plan. This information is for education. Always discuss your individual situation with your healthcare provider. I've outlined several reputable resources here, which you may find valuable for further information on this topic. These include the National Comprehensive Cancer Network Clinical Practice Guidelines, the American Society of Clinical Oncology Guidelines on Potentially Curable Pancreatic Cancer, and the International Consensus on Definition and Criteria of Borderline Resectable Pancreatic Ductal Adenocarcinoma. All links are available in the description below. Thank you for watching.